Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are kicking off a new chapter in which we're going to be talking about the wrist and hand. In this first video, we're just going to be talking about the anatomy. It's not going to be a full deep dive into all of the insertions and innervations. We're just going to talk about the bones, muscles, ligaments, tendons, and articulations to sort of set the stage for the pathology moving forward. Then in the next video, we'll talk about the very common carpal tunnel syndrome and its lesser known sister, Guillain Canal syndrome. Then we'll talk about fractures and dislocations of the hand and how to distinguish them. We'll talk about distortions of the hand, which will be from nerve injuries. Then we will finish with de Quervain tenosynovitis, Dupuytren contracture, a ganglion cyst, and last and certainly not least, finger injuries. So without further ado, let's hop into it. Alright, so the goal for this video is that we can get comfortable with the anatomy so that we can understand the pathology a little easier moving forward. Now, it's pretty rare that question writers will ever give you an x-ray of a healthy hand and circle out a bone and say, "What bone is this?" Instead, a lot of anatomy questions are sort of phrased through the lens of pathology. So we'll go over some of the relevant pathologies when we talk about the anatomical structures as we go through the hand. So let's start with the bones, and we're going to start proximally. So we'll start with the radius and the ulna. All right, we'll start with our radius, which again will be our lateral forearm bone. And remember, whenever I'm talking about medial lateral, we're talking about anatomical position. So the radius will be out here on the side of the thumb. In contrast, the ulna will be the medial forearm bone, which is going to be a little thinner distally near the wrist, and that is going to be on the side of the pinky. And if we move distally from those, then we are going to find our carpals, which will be the 8 small irregular bones at the base of the hand. So the base of our hand is really just a bag of bones that's kind of held together by ligaments. And as a refresher, can you recall the name of all 8 of these bones in their order? One thing that helps me remember the names of these bones is the mnemonic, "So long the pinky, here comes the thumb," which will give us an acronym for the names of the bones, where we have scaphoid lunate triquetrum, pisiform, hamate capitate, trapezoid trapezium. But of course, now we're talking about pathology, and in pathology, not all bones are created equal. Some are more important than others. And so we're going to go over some of the more important ones and why they're more important. So starting with the scaphoid. So the scaphoid will be the most common carpal bone that gets fractured. And this is very common when falling on an outstretched hand. And so the scaphoid will be A here on our diagram, and that's the large peanut or boat-shaped bone at the side of the thumb. Additionally, we'll talk about the hook of hamate and that fracture leading to Guillain Canal syndrome. So recall that the hook of hamate is a little protrusion of that hamate that kind of sticks up and almost points straight into the palm. And that hook can be broken, and if it is, it can damage the ulnar nerve and lead to Guillain Canal syndrome. We'll talk about that in a later video. And so again, that hamate bone is going to be right here, with the hook sort of being shown sticking out right there. I've also noted out pisiform, which is bone D, because these can also be injured in falling on an outstretched hand, although much rarer than a scaphoid fracture. All right, now moving past our carpal bones, we'll talk about the metacarpals, which will be the long bones in the middle of the hand that we can see here. Now, the way I like to think about this is that meta means after or beyond, or sometimes used as change in English. And so metacarpals are going to be the change between the carpals and the phalanges. And so remember, the joint between the metacarpals and the proximal phalanges, the metacarpal phalangeal joint, is what's going to make up our knuckles. And so if there's an injury from punching something that we weren't supposed to punch, then our metacarpals are at risk of being fractured in that injury. And lastly, we'll talk about the phalanges, which are the long bones that will constitute our fingers. So you can see that most of our fingers will have a proximal, intermediate, and distal phalanges, except our poor little thumb will only have a proximal and distal phalanges. There are, of course, some defects that will give patients triphalangeal thumbs, one of them being diamond blackfan anemia, in which case the patient would also have pure red cell aplasia. All right, getting back on track to MSK, let's talk about our muscles. So I've split up our muscles here by their innervation, either by the median nerve or by the ulnar nerve. And I think that's important because understanding what muscles are innervated by what nerves is important for understanding things like the distortions of the hand. All right, so let's start off with the median nerve. And remember that that median nerve is going to come up on the lateral or the side with the thumb and is going to innervate the muscles and skin in that area. And so that will include our first and second lumbricals, which will be responsible for flexion at the metacarpal phalangeal joint and extension at the proximal and distal interphalangeal joints. And so that's this motion here. Remember, we're going to be flexing at the MCP, extending at the DIP and PIP. lumbrical day, people don't skip it at the gym. Additionally, the median nerve will be innervating the thenar muscles of the hand. So that will be our abduction, flexion, and opposition of the thumb. And so if there's injury to the median nerve, then we're going to see thenar eminence atrophy, in which that meaty part below the thumb becomes a little less median and wastes away. Now let's move on and talk about our ulnar nerve. So our ulnar nerve will be coming up on the medial side of the hand, or the side with the pinky, and will innervate the muscles and skin on this side, starting with the third and fourth lumbricals. So again, this will be flexion at the MCP, extension at the PIP, and DIP. So this will be the lumbrical motion for only the pinky and ring finger. You can see that the median nerve lumbricals and the ulnar nerve lumbricals. Additionally, the ulnar nerve will innervate the hypothenar muscles of the hand, which will be opposition, flexion, and adduction of the pinky. So the hypothenar eminence will be at risk for muscle wasting if there's ulnar nerve injury. And of course, we cannot forget our dorsal and palmar interossei muscles, which will also be innervated by the ulnar nerve. And again, those will contribute to adduction and abduction of our fingers. And before we move on to the ligaments and tendons, I really want to emphasize the importance of these lumbricals and understanding how their split innervation will present with hand distortions. So remember, this is the action of the lumbricals. And so if we lose action of these lumbricals, we're going to do the opposite. We're going to extend at the MCP and flex at the PIP and DIP. And keep in mind how this will look differently depending on what nerve is injured. We'll talk about that in detail in the hand distortion video, so make sure to look out for that. All right, starting with the transverse carpal ligament. Now, the big pathology to look out for with this one is carpal tunnel syndrome. And so that transverse carpal ligament will run on that palmar side of the wrist, and it will run over the median nerve and a lot of flexors of the fingers and hand. And in the upcoming video on carpal tunnel syndrome, then we will look at how the transverse carpal ligament might compress the median nerve, or what else might compress the median nerve leading to this syndrome. In contrast, the palmar carpal ligament will run over the ulnar nerve on the medial side of the hand and will likely contribute to K.A.N. canal syndrome if there's compression of the ulnar nerve there. And lastly, we'll talk about the palmar aponeurosis, which is this fibrous fascia that sort of extends from the flexor retinaculum into the hand. And if there's overgrowth of this fascia, then that can lead to what we call Dupuytren's contracture. All right, and lastly, we'll talk about articulations. Now, these all follow pretty simple naming conventions, but we will focus a little bit in understanding at the wrist bone where the carpal joints will meet with the forearm bones. So starting with the radiocarpal joint, so this will be the radius meeting with the proximal carpal joints other than the pisiform. So which ones are those going to be? So A, the scaphoid, B, the lunate, and C, the triquetrum. The pisiform will not be necessarily a part of that radiocarpal joint. In the ulnocarpal joint, we will have the ulna articulating with the lunate and triquetrum of the carpal bone. So we look up here, we can see the ulna sort of connecting with B and C, the lunate and triquetrum of the carpal bone. And if you've listened to me talk about lumbricals at all, you may already be a master of the metacarpal phalangeal joint, which will be between the metacarpals and phalanges, as well as the interphalangeal joint, between the phalanges, the distal and proximal interphalangeal joints. So if we look at our hand, obviously these will be our MCP, our metacarpal phalangeal joints, and here we'll have our proximal interphalangeal joints and our distal interphalangeal joints. All right, let's do a recap and then we'll do a quick practice question together. Starting proximally and moving distally, we'll have our radius and ulna move into our 8 carpal bones, and then we'll have our metacarpals moving into our proximal phalanges, our intermediate phalanges at all except the thumb, and we will have our distal phalanges at the end of every digit. The muscles of the hand will either be innervated by the median or the ulnar nerve, with the median nerve innervating the first 2 lumbricals and the thenar muscles of the hand, so think thumb actions, and our ulnar nerve will innervate our 3rd and 4th lumbricals, as well as our hypothenar muscles of the hand, think actions of the pinky, as well as the dorsal and palmar interossei muscles. With our ligaments and tendons, we have our transverse carpal ligament that will be holding in our flexor tendons and median nerve and may contribute to carpal tunnel syndrome. Our palmar carpal ligament may contribute to K.A.N. canal syndrome if there's compression of that ulnar nerve. And our palmar aponeurosis is that fibrous tissue that sort of bands between the skin and the muscles of the hand, and may lead to Dupuytren contracture if there's overgrowth. And finally, we have our articulations, where we have our radiocarpal joint out here on the lateral side, our ulnocarpal joint on the medial side, And of course, you are all experts at the metacarpal phalangeal joint here, and our proximal interphalangeal joints and distal interphalangeal joints. And a practice question might sound like this. A 37-year-old male comes into your clinic complaining of left-sided hand pain after hitting the floor with his racket after losing a pickleball match. The patient reports swinging his racket as hard as he could at the floor after losing, and reports feeling pain and swelling immediately after impact. Vital signs are within normal limits. On physical examination, there's decreased sensation in the pinky and ring finger on the affected hand and 2 out of 5 grip strength. X-ray reveals fracture at the hook of hamate. Name one action of the hand muscles that is innervated by the most likely injured nerve in this patient. So our patient here is a little bit of a sore loser, and after his humiliating defeat is grabbing his tennis racket, swings it at the floor, and gives himself a fracture at the hook of hamate. Now, I mentioned that this can lead to Guillain Canal syndrome, and so we know that the affected nerve is the ulnar nerve. And so any of these actions would work. Third and fourth lumbricals would be flexion at the MCP, extension at the PIP, and DIP. Another action would be opposition, flexion, or adduction of the pinky, or even abduction, adduction of the fingers. All right, that's everything for me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we will be talking about carpal tunnel syndrome. So what is carpal tunnel syndrome, or CTS, as I might call it in this video? Well, in its simplest way, it is compression of the median nerve as it runs through the carpal tunnel, hence giving it the name carpal tunnel syndrome. And so let's take a look at our diagram here to the right before we get into our text. So up here we can see some of the carpal bones of the hand, and right here we're going to see that carpal transverse ligament that's involved in compression of the nerve. And they have it labeled out nice for us that this nerve is being compressed by the nearby structures, and that's going to lead to pain, paresthesias, and weakness in the hand. All right, so let's hop in and talk about our etiology. Now, something I think it's important to talk about with CTS is that it's a very, very common syndrome, and it's not particularly complex, right? There's just median nerve compression or damage, and so we see the pain in the hand. And so one of the ways that question writers will try to complicate the situation, because that's what they're paid to do, is by asking you about the etiology and pathophysiology involved. So I'm going to spend a little extra time talking about the mechanisms of how each of these etiologies are contributing to median nerve compression. So let's start and talk about things that can increase risk from swelling. So first up, we'll talk about pregnancy. So recall that during pregnancy, there's an increase in the red blood cell count, but an even greater increase in the plasma volume. And so that increased blood has to go somewhere. And so the vessels are going to be a little swollen, and there's also going to be some edema. One of the complaints that a lot of women have with pregnancy is that there's swelling in the feet and in the hands, and that swelling can contribute to compression of the median nerve, and so that can lead to carpal tunnel syndrome. Additionally, hypothyroidism can increase your risk of CTS, and this is really done by 2 mechanisms. And so the first way this can contribute to an increased risk of CTS is by causing obesity. Remember, in hypothyroidism, your whole system kind of slows down, and weight gain tends to be a presenting symptoms of a lot of patients. And sometimes that obesity can mean extra tissue here in the wrist region, which can compress the median nerve. The second mechanism is that in primary hypothyroidism, we can have deposition of those glycosaminoglycans, or GAGs, or mucopolysaccharides as they're sometimes called. And so traditionally, these are found in the pretibial region or in the eye, causing swelling there. But this can also happen in the wrist. And if it does happen in the wrist, then that can contribute to carpal tunnel syndrome. And there's also an increased risk from rheumatoid arthritis. Remember that this can cause inflammation and swelling in this wrist region, and that can contribute further to compression of the median nerve. And so there are a few more associated conditions with carpal tunnel syndrome, one of them being acromegaly. So remember, this is if we have excess growth hormone in an adult. And unlike some of the other things that will cause swelling and increased fluid, acromegaly will actually cause overgrowth of the bones in the hand. And so the growth of those bones will compress the nerve, leading to the pain and symptoms seen in CTS. Diabetes mellitus will also carry an associated risk, and this is probably due in part to the fact that there's an association between diabetes mellitus and obesity, which we also know can contribute to median nerve compression. But the high blood sugar levels found in diabetes patients may also contribute to inflammation in that wrist area, which will then cause swelling and compression of the median nerve. And another less common associated risk would be amyloidosis. And so recall that amyloid is going to be that apple green birefringence protein that has deposition all over the body. And while we know it can deposit in organs like the heart and the liver and kidneys, it can also deposit in areas that are a little more innocuous, like your wrist. And so maybe in a question, it starts out describing a patient with late-stage renal disease. And so you get your nephrology gears turning, but then at the very end, they tell you that the patient has wrist pain and they want to know what the pathophysiology is. Well, maybe this patient is on dialysis and that is leading to amyloid deposition in that wrist area. And so this is another possible cause of CTS to keep in mind. And lastly, we can talk about mechanical overuse. So in a question stem, this might be somebody that types at their desk a lot all day. And a lot of people think that this is the only cause of carpal tunnel syndrome. But as we can see, there's a lot of things that can present a risk, and sometimes it is idiopathic. Sometimes none of these are true in a patient. But it's important to keep in mind all of the different things that can contribute to swelling or growth in an area that will ultimately compress the median nerve. And so moving on to the pathophysiology, as I've mentioned a couple times already, it is compression of the median nerve between the carpal bones and that carpal transverse ligament. All right, moving on to the presentation. So what are these patients going to look like? Well, there will be paresthesia and pain in the median area innervation. Down here, we have the area innervated by the median nerve. So again, that will be our palmar thumb, index, middle, and 1/2 of our ring finger. That ring finger will be split down the middle and share it with our ulnar nerve. Something to keep in mind is that these patients may have pain radiate up the forearm. So it doesn't strictly just have to be in here and that they never have any pain below the wrist. And the last thing I'll mention is that the palmar cutaneous branch is spared because it branches before the carpal tunnel. So if we take a look over here at our hand, they don't have it, so I'll draw it in, is that the palmar cutaneous branch is actually going to come off before and then go and innervate the palmar area above that carpal transverse ligament. What that means is in a patient with CTS, they may still have sensation here at the palmar area, and so their complaint will be more likely about the fingers or strength involved in the hand. And if this median nerve is compressed for a long time, then we may have thenar eminence atrophy. So the thenar eminence, again, is this area here sort of at the base of the thumb. And so if we see that muscle wasting, this nice little curve that we see on all hands is going to kind of go away, and it'll be pretty straight between that thumb down to the wrist. Additionally, patients may complain of weakened grip strength, so there may be motor deficits in addition to the sensory ones. Remember that the median nerve will innervate the actions of that thumb as well as the first 2 lumbricals, which will contribute to a weakened grip. And lastly, a more interesting finding is that the symptoms are often worsened at night. Now, I want you to try and think about why that might be before I tell you. So remember that a lot of the causes that are compressing that median nerve are about fluid buildup and swelling and extra mass in this wrist region that are compressing the nerve. So at nighttime, when patients go to bed and they stop using the muscles in their hand and arm and they kind of relax, then the fluid is going to redistribute in that area, increasing the compression and increasing the symptoms of the patient. All right, let's move on and talk about diagnostics. So this is often a clinical diagnosis. Again, it's a very, very common syndrome. If there was trauma, then we would image to rule out other pathologies, but we're likely to suspect CTS first. There are clinical tests that you should know about. The first being Tinel's sign. So this is when there's percussion of the anterior wrist and it elicits tingling. So the patient will have their wrist, and if the physician taps in this area, then that will further compress the median nerve and sort of cause tingling up the median nerve innervation area. Additionally, there is Phelan's test, in which 90-degree wrist flexion elicits tingling. Patients will be asked to hold the back of their hands together like this, and they'll hold it for a while, and if holding that position elicits pain and tingling and worsens their symptoms, then that is another positive sign that leads us to carpal tunnel syndrome. And lastly, we'll talk about the management of these patients. So generally, we like to opt for conservative management, in which we can splint, rest, give them corticosteroid injections for pain in addition to NSAIDs, and then eventually physical therapy to strengthen the muscles involved. But of course, we may need surgical intervention, especially if a patient's symptoms are refractory to the conservative treatment. All right, so we'll do a recap and then we'll do a quick practice question together. So there are a lot of different things that can possibly contribute to your risk of CTS. So pregnancy, increased plasma volume, more blood flow, more swelling. Hypothyroidism, increase of obesity, but also GAG deposition. Rheumatoid arthritis, we're going to have inflammation in that wrist. Inflammation leads to irritation, compression of the median nerve. Acromegaly will cause an overgrowth of the carpal bones that can compress the nerve. In diabetes patients, the high blood sugar levels can lead to compression and inflammation, which will further compress the median nerve. And in amyloidosis, there can be deposition of these proteins that will increase the swelling and inflammation and compress the median nerve. And of course, mechanical overuse, so somebody who's a typewriter or a harp player. And again, that pathophysiology is compression of the median nerve and the carpal transverse ligament. These patients will have paresthesia or tingling and pain in the median nerve area innervation. So half of the ring finger and then middle finger, pointer finger, and thumb, with much of the palm. But this area may be spared because of the branching of the palmar cutaneous branch. Remember, they may have thenar eminence atrophy, and patients will complain of weakened grip strength. And because these symptoms are worse at night, the pain may be keeping patients up and preventing them from sleeping. Although it is often a clinical diagnosis, we can use Tunnell's sign, in which we're going to percuss the wrist, or we can use Phelan's test, in which we use 90-degree wrist flexion. And we will start treatment of this in a conservative fashion with rest and splinting, maybe corticosteroid injections for pain, and physical therapy. But of course, the need for surgery may arise. And a practice question might sound something like this. A 67-year-old woman presents to your clinic with tingling in her left hand that she says is sometimes painful at night. The patient reports first noticing the tingling sensation while typing at work. The vital signs are within normal limits. On physical examination, there is positive Phelan's test as well as decreased sensation in the 3 lateral fingers. Grip strength is 3 out of 5, and X-ray appears normal. What is the ligament most likely involved in this patient's presentation? So this patient has pain in these lateral 3 fingers that gets worsened at night. So we are thinking about carpal tunnel syndrome. And the ligament most involved in this process will be the carpal transverse ligament, which helps to form that carpal tunnel. All right, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we will be going over K.A.N. canal syndrome. So this is pretty similar to carpal tunnel syndrome. We're talking about compression of a nerve through an anatomical structure. But this time, instead of the carpal transverse ligament compressing the median nerve, we're talking about the palmar carpal ligament compressing the ulnar nerve. All right, we'll get this kicked off talking about etiology. So very, very commonly from sports-related compression injuries, the most classic one is going to be handlebar compression on cyclists. So when those road cyclists are thinking to themselves, I need to go out and be a nuisance to drivers for several hours, during those several hours, they have their hands resting on their handlebars with a lot of their weight on it. And that compression is going to be here in that K.A.N. canal, which can then compress the ulnar nerve. I've also seen this in a question with somebody using a jackhammer for several hours at work. And so think of anything that can physically compress over long periods of time in that K.A.N. tunnel can compress the ulnar nerve and lead to these symptoms. Additionally, this can be associated with other conditions like a ganglion cyst, which is a synovial fluid buildup, or an ulnar artery aneurysm. So recall that in this K.A.N. canal that we have here, running alongside the ulnar nerve will be the ulnar artery. And so if that artery grows from an aneurysm, that can obviously compress the ulnar nerve. And lastly, we can have more traumatic instances such as a hook of hamate fracture that can injure the ulnar nerve. So if we take a look at our diagram here to the right, we can see that the ulnar nerve will go up and it'll cross through this palmar carpal ligament. And as it continues through the hand, it'll pass by the hook of hamate that is labeled out here. And so if that hook of hamate gets fractured, it can obviously press into or lacerate the ulnar nerve. And this is an injury that we see in patients while they're holding something and then suffer a traumatic blow. So maybe they hit their racket on a wall or they swing a baseball bat wrong. And so I want you to notice the theme that a lot of this happens when we're holding on to something or gripping something. So if a patient sustains an injury while gripping something, and then they have weakness and sensitivity in this region, then you should already be thinking about ulnar nerve injury. All right, moving on to talk about pathophysiology. So as I mentioned, this is compression of the ulnar nerve between the carpal bones and the palmar carpal ligament. So I've sketched in a little cross section of the wrist here. So this is the medial side and the lateral side, and this is the dorsum of the wrist and the palmar aspect of the wrist. And so we can see that the ulnar nerve here is running through the K.A.N. canal, where the median nerve is running in the carpal tunnel. So they're not in the same tunnel, but they do share similar pathophysiologies in that they are compression of the nerve by the ligament involved or nearby structures. Moving on to presentation, this will be pretty analogous to carpal tunnel syndrome, but for the ulnar nerve. So the paresthesia and pain will be in the ulnar nerve distribution innervation rather than the median nerve innervation. So again, if we look down here, we can see that is going to be the medial half of the ring finger in addition to the pinky. And that includes both the dorsal and the palmar aspect of the hand. And again, the ulnar nerve is responsible for the hypothenar muscles. And so damage to that nerve can lead to hypothenar eminence atrophy if those muscles aren't getting innervated. And lastly, this may present with ulnar claw. So remember what I said about the lumbricals having split innervation. So remember the third and fourth lumbricals are innervated by the ulnar nerve. And the lumbricals are going to do this action at the third and fourth fingers. So if we lose innervation of those lumbricals, then we're going to have the opposite action. And so patients may present like this, which is called ulnar claw, with the Guillain-Canal syndrome. So one thing that I think is worth mentioning about the presentation before we move on is that question writers will probably not be testing your ability to distinguish carpal tunnel syndrome from Guillain-Canal syndrome. The presentations are too different. We're talking about brand new nerve innervations, different fingers, different muscle weaknesses. Instead, they may be more likely to target things that have similar presentations. So instead, consider cubital tunnel syndrome, where there's ulnar nerve damage in the elbow. And because the ulnar nerve is also damaged in cubital tunnel syndrome, we can have very similar presentations. There may be pain in the ulnar nerve distribution of the hand, hypothenar eminence atrophy, or even ulnar claw. So how do we distinguish them? The giveaway will be in both the history, but also whether or not the symptoms are worsened with activity at the elbow. If flexion of the elbow, if palpation of the elbow worsen the symptoms, we're talking about cubital tunnel syndrome, not Guillain-Canal syndrome. Additionally, cubital tunnel syndrome can also present with weaknesses of some of the flexors of the wrist and hand, such as flexor carpi ulnaris or the medial half of flexor digitorum profundus. All right, moving on to diagnostics. So this will usually be a clinical diagnosis based off the presentation we've talked about above, but a specific test that may be used is the Fremont sign, which will show weakness with adduction when trying to hold a piece of paper. So let me try to demonstrate what this might look like. So you'll take a piece of paper and you'll put it between the patient's thumb and index finger and ask them to hold it there while you resist and pull. Now, notice what I'm doing with my thumb. I'm adducting it very close to my palm, and that's what's holding the paper together. I'm not pinching it and bending my thumb, I'm just adducting it. And so remember that the ulnar nerve is responsible for adduction of the thumb by the adductor pollicis brevis. And so what you may notice in a patient that has ulnar nerve injury is that they'll need to bend that thumb in order to hold the paper so that they can use other muscles that aren't innervated by the ulnar nerve to hold the paper together. And remember that because a question stem might not necessarily say there's a positive Fremont sign. Instead, they may use a term that says there's compensatory flexion of the interphalangeal joint on the thumb when trying to resist moving a piece of paper from their fingers. And what that's essentially saying is they've lost adduction of the thumb because there's ulnar nerve injury. And if we do any imaging, then we may take an x-ray to rule out fractures or dislocations, such as if we suspect a hook of hamate fracture, but this will appear normal in most cases of Guillain-Canal syndrome. The management of Guillain-Canal syndrome will start conservatively with splinting, NSAIDs for pain relief, corticosteroid injections for pain relief, and physical therapy. But of course, as always, we have to consider surgical intervention, especially if the symptoms are refractory to the treatment. All right, let's do a recap and then we'll do a practice question together. So Guillain-Canal syndrome is very often found in compression injuries, classically the handlebar pressure from cyclists, but can also be compression of a nearby ganglion cyst or an aneurysm of the ulnar artery, or can be from a traumatic hook of hamate fracture. Recall that the ulnar nerve is not held by the carpal tunnel, but instead by the palmar carpal ligament. These patients may present with paresthesia and pain in the ulnar nerve distribution and may have weakened muscles, which may show with hypothenar eminence atrophy or weakened grip, and may even present with ulnar claw. Again, we want to distinguish this from cubital tunnel syndrome, where there may be motor deficits from some of the forearm muscles or pain with flexion of the elbow. In Guillain-Canal syndrome, flexion of the elbow should not worsen the symptoms. It is often a clinical diagnosis in which we may use Fremont sign to test the strength of thumb adduction. And the treatment for this condition will start conservatively with splinting, rest, NSAIDs, cortico injection, and physical therapy, but surgical intervention may be necessary. And a practice question might sound something like this. A 42-year-old male presents to your clinic with weakness in his right hand. The patient is a construction worker, and he reports that he's sometimes noticed dropping his tools at work. Vital signs are within normal limits. On physical exam, there is decreased sensation in the pinky finger as well as the medial half of the ring finger, as well as 3 out of 5 grip strength. There is a positive Fremont sign. Flexion and palpation at the elbow do not worsen the patient's symptoms. What action of the injured nerve in this patient elicits the positive Fremont sign? So this patient is a construction worker, so maybe using a jackhammer or just has compression from his hands of work. So our pain comes in and has weakness in his medial hand as well as decreased sensation on that dorsal pinky and 1/2 ring finger. So we suspect ulnar nerve injury. And since there is no worsening of the symptoms with flexion at the elbow, we are beginning to think Guillain-Canal syndrome rather than cubital tunnel syndrome. And again, on that Fremont sign, the Fremont sign will be testing adduction of the thumb. So adductor pollicis brevis is the muscle involved. The ulnar nerve is the innervator of that muscle. All right, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we are going to be going over some fractures and dislocations of the hand. So let's hop into it. And let's start and go over some of the bones of the hand. Just as a quick recap, make sure that we are going to start good and ready to go. So down here we have the carpal bones, which are beautifully labeled out. We'll have our radius and our ulna at the wrist in both the anterior and posterior view for your viewing pleasure. All right, now let's hop in. Now we got a couple different fractures that we're going to talk about. So we're going to start with the scaphoid fracture. And this is going to be most commonly caused by a foosh, falling on an outstretched hand, especially with radial deviation. So let's orient ourselves. So the scaphoid is going to be this peanut-shaped bone out here near the base of the thumb. So that scaphoid is going to help to form that radiocarpal joint on the side of the thumb. So I want you to imagine that you are walking and all of a sudden you find yourself fooshing. And while you're falling with your outstretched hand, you deviate your fingers in the radial direction. And that is going to orient the scaphoid to be a little more prone to contact with the ground and be fractured in the process. Another common injury of the carpal bones being lunate dislocation. Again, the most common cause being a foosh, this time with ulnar deviation. So the lunate is going to be a little more toward the ulnar side of the hand. And again, this is being dislocated, not fractured. As I've mentioned before, the carpal bones of the hand are really just like a small bag of bones that are being held together by ligaments. And so if those ligaments tear in the event of falling on an outstretched hand, then we can have a dislocation of that bone, usually in the palmar direction. Next, I'll talk about the hook of hamate fracture. And this can also happen from falling on an outstretched hand, but we will also typically see it with blunt trauma while gripping an object, very often a sports injury, with a golf club or a baseball bat. So the hamate will be that bone here at the very base of the pinky's metacarpal. Also recall that that hamate has a small protrusion, which we call the hook of the hamate. And while you are gripping an object, if you can imagine, maybe here's my baseball bat that I am holding on to, that hook of hamate is going to be at risk of fracture because it's going to be pressed up against the object you're gripping. And the last type of injury we'll talk about for this video will be a metacarpal neck fracture, sometimes called the boxer's fracture. And that's because this often happens with blunt trauma while striking with a closed fist. So recall that our knuckles are right here, right at the metacarpal phalangeal joints. And so if we have a closed fist and we hit something, then that force is going to go directly on to those metacarpals. And so if the force is strong enough, then we may cause a fracture at the neck of that metacarpal. And this is typically going to be in the 4th and 5th digits. All right, now let's move on to presentation because that's going to be a big way that we can help to distinguish these pathologies from one another. So starting with our scaphoid fracture, a very common presentation that will come with this pathology is pain with palpation of the anatomical snuff box. So where is that? So if we'll take a look at my hand here, we can see that this tendon running up my thumb is extensor pollicis longus. And so the anatomical snuff box will sort of be that divot, that area below that tendon. And of course, it's called the snuff box because back in the day, this is where people used to hold their tobacco before inhaling it. Back when consuming tobacco was cool and not unhealthy or carcinogenic like it is today. And although question stems will often point you toward a scaphoid fracture with that anatomical snuff box, in real life, not all patients have pain in that area. Additionally, patients may notice a decrease in the grip strength. Now, something worth knowing about the scaphoid fracture is that this is the most common fracture of a carpal bone. Test riders love you to know the most common things. They'll give you a general presentation and say, what is this? So if a patient falls on an outstretched hand and maybe they have some pain in the snuff box, you need to immediately be thinking of a scaphoid fracture. And relevant complications of that scaphoid fracture will include avascular necrosis, which basically just means blood supply is not good and the bone is dying. This can lead to non-union, which is essentially just unhealed bone even over a long period of time, sometimes over 6 months, and there's still no healing. And part of the reason that the scaphoid is infamous for having this avascular necrosis is because it has a retrograde blood flow supply. So if we take a look at the radial artery that I drew in here on our anterior and posterior view, then we can take a look at what this means and why it contributes to avascular necrosis. So coming off of that radial artery, we have both a volar or palmar branch and a dorsal branch. So I'll take a closer look here at the anterior view so that we can get a close-up of what's happening. So the big idea here is that the branch to the scaphoid is actually going to insert distally into the scaphoid. And so the blood will travel down before getting to the proximal part. What that means is that this area gets really good blood supply because this is right where the vessel comes in. But down here, more proximal, is not getting very good blood supply. And so if there is a fracture in this area, that low blood supply means that we're going to have a hard time healing and we can have a non-union even after many, many months.
And the same is true for the dorsal side. You can see that the dorsal artery will insert a little more distally and then travel backwards toward the more proximal side of the scaphoid. All right, let's move on and talk about a lunate dislocation. So, as with any of the injuries here, pain is a common presenting symptom. There may be wrist swelling, and we can even have possible median nerve injury with a lunate dislocation. And of course, patients may have a decreased grip strength. Remember what I mentioned earlier, that it's typically a volar dislocation. So this lunate is going to come and be displaced anteriorly. And remember that the median nerve is going to be running through that carpal tunnel to get to the hand. And so the lunate can compress the median nerve. And if we have that, in addition to the pain and swelling, we may have an acute carpal tunnel syndrome. So remember what that looks like, that there will be pain, weakness, or paresthesias in that median nerve distribution of the hand. We can contrast that with a hook of hamate fracture, in which we will still see pain and decreased grip strength, but more likely to be a possible ulnar nerve injury. So remember that that ulnar nerve is going to run up through the ulnar side, through K.A.N.'s canal, and then up the hand, where it will pass by that hook of hamate. And so in the event that we fracture this hook of hamate and we compress or damage the ulnar nerve, we may present with acute K.A.N. canal syndrome. So remember, there will be pain, paresthesias, or weakness on the ulnar side of the hand. And finally, the metacarpal neck fracture or boxer's fracture will of course have pain and swelling of the affected metacarpal. Remember, this is the only injury that we're talking about that is not of a carpal bone, but rather the metacarpal bones. As I mentioned, this is most often in the 4th and 5th metacarpals, so your ring finger and pinky finger, and of course there can be neurovascular compromise if a nerve or artery is severed in the process. This is a little easy to distinguish from others because it's not in our carpal bone area, and it is very classically by striking with a fist. All right, moving on to talk about diagnostics. So remember that all of these injuries have traumatic onset, unlike carpal tunnel or K.A.N. canal syndrome, which can have slow onset over a couple of weeks to months. We're talking about phuches and traumas. And so if a patient comes in with hand pain after trauma, that's going to be an indication for imaging. So we're going to get an x-ray to show for signs of fracture or displacement to help us distinguish specifically which bone is injured. Something to keep in mind is that the scaphoid fracture might not show on x-ray, which is really unfortunate because, as I said, this has a risk of avascular necrosis and not healing, and that's a very bad thing to not pick up on. And so if a patient is clinically presenting with a scaphoid fracture, so maybe they had a fall and there's injury in that anatomical snuff box and pain with palpation, but the x-ray appears normal, that doesn't mean that you can send them away and say, okay, you're fine. If the x-ray is normal, we may ask the patient to splint up their hand and try again for another x-ray in 2 weeks. If the patient can't splint their hand, or that second x-ray after the 14 days of splinting is also normal, then we may consider an MRI to visualize the structures better and confirm that there isn't a scaphoid fracture. And finally, let's talk about management of these cases. So, of course, as always, we'll opt for conservative management first, splinting, analgesics, and rest to address the pain of the patient. And now most of these are fractures, but that dislocation of the lunate will often require a surgical reduction to put it back into place. And of course, the other injuries may warrant surgical intervention if they are refractory to conservative treatment. All right, let's do a recap and then we'll do a little practice question together. So all of these injuries will be trauma related, with phuche being likely to cause 3 of the 4, and blunt trauma with a fist likely to cause the metacarpal neck fracture, also known as boxer's fracture. Something to point out, boxer's fracture is different than boxer's knuckle. Boxer's knuckle is an injury of the sagittal band that runs across the middle finger. Additionally, blunt trauma while gripping an object is pretty classical for a hook of hamate fracture. Now we're going to distinguish these in the presentation by the location of the pain as well as the deficits involved. So in the scaphoid fracture, there will be often pain in that anatomical snuff box. And because of the risk of avascular necrosis and not healing, sometimes in a question, this can be a patient that injured themselves many months ago, but continues to have painful symptoms. The lunate dislocation can contribute to carpal tunnel syndrome by median nerve compression, and the hook of hamate fracture can contribute to K.A.N. canal syndrome by ulnar nerve compression. And remember, boxer's fracture is going to very often be 4th and 5th metacarpals after punching an object that you probably weren't supposed to punch. Imaging with an x-ray will be a key diagnostic in identifying which structure is involved and if it was dislocated or fractured. But remember that a scaphoid fracture is often not visible on the first x-ray. And treatment will begin with a focus on splinting, pain management, and rest, but may progress to surgery, and a lunate dislocation will specifically require a manual reduction or very often a surgical reduction to put the bone back in place with the other carpal bones. And a practice question might sound like this. A 22-year-old male presents to your clinic with right-handed pain that has persisted for many months. The patient reports that many months ago he had fallen on his hand during a basketball game with initial pain, but resumed activity after the pain had subsided after a couple of weeks. But the pain has since returned for the last couple of months. Vital signs are within normal limits. On physical exam, you notice that there is pain with palpation of the anatomical snuff box and 3 out of 5 grip strength, but no changes to sensation and no clawing. Which of the following areas of bone was most likely to have been injured in this patient? Was it the distal hamate, the proximal hamate, the distal scaphoid, or the proximal scaphoid? So this patient had a fouche many months ago, and now they are coming back with pain in that anatomical snuff box. And remember that that scaphoid injury is at risk of avascular necrosis because of that retrograde blood flow. And so out of our options, we had distal hamate, proximal hamate, distal scaphoid, proximal scaphoid. We mentioned that the distal scaphoid is better vascularized than the proximal scaphoid because of that retrograde blood flow. So of the 4 options listed, the proximal scaphoid is the most likely fractured part of this patient's hand. All right, that's everything for me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we will be going over distortions of the hand. Now, this is a great example of a pathology that you could memorize, but is going to be a lot easier to understand. So let's go over some of the principles necessary to understand this. That way we won't have to waste our time memorizing anything. All right, let's talk about the lumbricals first. So the lumbricals are going to be these 4 muscles in our hand, and the action of these lumbricals will be flexion at the MCP joint here, and extension at the proximal and distal interphalangeal joints here. So this is our lumbrical action. And also recall that the lumbricals are split innervated, with the first 2 being innervated by the median nerve, while the 3rd and 4th lumbricals will be innervated by the ulnar nerve. And so again, to show you, this would be both the ulnar and the median nerve. This would be just the median nerve, and this would be just the ulnar nerve lumbricals. And the other principle to talk about is that across every joint in our body, there's a balance between all the muscles, even at rest. And so when you look at your hand in a neutral position, it's not that no muscles are firing, it's that there's a balance between all of the muscles that are firing, in between your flexors and your extensors. And so that means our lumbricals will be contributing to flexion at the MCP, extension at the PIP at rest. So if we lose action of those lumbricals, what does that mean for the presentation of our hand? Well, it means that the other side of that balance is going to win out. So instead of flexing at the MCP, the extensors at the MCP are going to win out. And instead of having that neutral position at the PIP-DIP, we are going to flex at the PIP-DIP. And this is a general principle that doesn't just apply to the hand. So if a patient comes in and their elbow is flexed all the way, then you might suspect that there's weakness in the tricep. Similarly, if a patient comes in and their hand is stuck in this position, then we might guess that the action that opposes this flexion, the lumbrical, is injured. Which leads into the last point I'll talk about, which is that distal lesions are going to have more prominent presentation than proximal lesions. And that's because distal lesions will present with more muscle imbalance. And so that imbalance is the presentation we're seeing. So greater imbalance means a greater, more prominent presentation. Okay, so now we can actually get into our slides. So we'll start first and talk about etiology. So this is a common presentation from very traumatic incidents, like after a motor vehicle accident. There could also be a less acute presentation from compression, so maybe a ganglion cyst, remember that synovial fluid buildup, or a tumor, Guyon canal syndrome. Think of anything that can sort of compress or damage the median and ulnar nerve may potentially lead to some hand distortion. All right, we'll move on and talk about pathophysiology. Now this is where it can seem confusing, but if you follow along, I promise it will make sense. So if we have ulnar nerve damage that is distal, that is farther down the arm, we're going to have a more intense presentation. We're going to see that patient have ulnar claw, which is what we see in this picture right here. This is what the patient's hand will look like at rest. We can see that those 3rd and 4th lumbricals are causing the awkward bending of these fingers. Now instead, if the ulnar nerve was more proximal, the patient might not come in and have this severe of a presentation. Instead, what would happen is that if we opened the patient's hand and we asked them to make a fist, then they would show us this right here, which is known as the OK sign. Now that's sort of going to be the opposite than if we had median nerve damage. So if there is distal median nerve damage, again, more severe presentation, distal median nerve damage will lead us to a median claw, which we see here. If the patient's hand looks like this at rest, where this first and second lumbrical are unable to extend the fingers all the way, then this is likely to be a distal median nerve injury. If instead there's a proximal median nerve injury, when we open the patient's hand and we say, make a fist for me, they will be unable to flex these two lumbricals, and therefore their hand will present like this, giving us a hand benediction. Okay, if that was confusing, no worries. Let's go into each of the presentations and their context to understand this pathology well. So the first one we'll go over is if there is extension at the metacarpal phalangeal joints, flexion at the proximal and distal interphalangeal joints in the pinky and ring finger. So that will be this image here. So if the patient is at rest or they're trying to extend their fingers, we can see that the third and fourth lumbricals on the fourth and fifth fingers are the ones that are impaired. So this will be ulnar claw if it is seen at rest or while trying to extend the fingers, again, because the third and fourth lumbricals are the ones that are affected that cause this presentation. However, if you open up a patient's hand and you ask them to close their hand and make a fist, and then this is the distortion of their hand, now we see that it's these two fingers that are impaired and unable to make a fist. So instead, this would be hand of benediction if seen when trying to close the hand into a fist. Because now, if they're trying to close a fist, it's the first two lumbricals innervated by the median nerve that are impacted. Okay, now let's talk about the other presentation. If we have extension at the MCP, flexion at the DIP in the middle and index finger. So that's what we see in this image here. So again, let's assume our patient comes in with their hand like this. We see flexion at the interphalangeal joints and extension at the metacarpal phalangeal joints in the index and middle finger. Because of this abnormality in these two fingers, we know that there is going to be median nerve injury. And so this is median claw if we see this at rest or while someone is trying to extend the fingers, because we have our first and second lumbricals affected from the median nerve. However, if this patient is trying to close their hand into a fist, it is the pinky and ring finger which are affected because they are unable to flex into a fist. And so in that case, we would see that there's ulnar nerve injury, and so we would suspect an OK sign because they're trying to close their hand into a fist, but the third and fourth lumbricals are affected. So remember, context matters. If this is what the patient hand looks like when they come in and they're just chilling at rest, we are thinking of a distal ulnar injury. But if this is the shape they make when trying to close a fist, it's the opposite. We're talking about a proximal median nerve injury. But again, there's no need to try and memorize this if we can understand our lumbricals. Median nerve will innervate the first two and ulnar nerve innervating lumbricals 3 and 4. So then when we understand the deficit that's going on in the patient, we can deduce what is the nerve involved. And again, as I've mentioned, distal lesions, which we'll see in ulnar and median claw, will have more prominent presentations. The OK sign and hand of benediction might not even present until you ask the patient to close their hand into a fist. And of course, we can reasonably assume that these patients will have reduced grip strength, especially on the side of the affected nerve, and that there may be an atrophy of the muscles of the affected nerve. So for our ulnar nerve injuries, we may see atrophy of the hypothenar eminence, whereas median nerve injuries, we may see atrophy of our thenar eminence. Like many things in this chapter, the diagnostics of this will often be a clinical diagnosis based off of the presentations and asking the patient to close their hand into a fist that we've already talked about. Of course, if the patient came in from a motor vehicle accident or we otherwise suspect a fracture, we may still get an X-ray to show for signs of fracture, but this would appear normal if there is no bone injury. Additionally, we may also do a nerve conduction study or an electromyography in order to assess the electrical activity of the nerves near the hand. One thing to mention about the presentation is that it is usually affecting one side of the hand, either the pinky and ring finger or the pointer and middle finger. That is different than if we had all of our fingers affected, such as in Klumpke palsy. Do you remember the site of injury for Klumpke palsy when we see total claw hand and bending of all of the fingers? So that would be a lower trunk injury of the brachial plexus, which would be nerve roots C8 and T1. And that makes sense, right? The lower trunk is a lot more proximal, and so we see less unevenness in the presentation. As we get more distal, we tend to have more prominent presentation because there's more imbalance. And finally, let's talk about management of these distortions. So as usual, we will start with conservative management, where we can brace the hand, give NSAIDs for pain relief, and very importantly, physical therapy in order to strengthen and restore that balance to the hand. But of course, we may need surgical intervention if the patient's symptoms are refractory to treatment. All right, let's do a recap and then we'll do a quick practice question together. So distortions of the hand can come from both traumatic acute incidences or less acute compression of the nerve. Anything that can damage or compress the nerve can cause a distortion of the hand. Recall that distal presentations will be more prominent than the proximal ones, and so ulnar nerve damage that's distally, that is closer to the wrist, will give us ulnar claw, while proximally, we will only see the OK sign when asked to make a fist. Similarly, median nerve damage that is distal and prominent will present with median claw, while proximal, maybe an injury in the forearm or near the elbow, will only present with hand of benediction when asked to make a fist. And again, for presentation, think about the lumbricals and how their impairment will indicate the type of injury. A patient comes in and they are unable to extend their fourth and fifth fingers even at rest. We already know distal ulnar injury. If their fourth and fifth fingers are unable to close, then we think about a proximal ulnar nerve injury. And just flip it for the median nerve. Patient comes in at rest and there is extension at the MCP, flexion at the interphalangeal joints. We are thinking distal median nerve injury. But if they are unable to flex those closed when asked to make a fist, we're talking about hand of benediction, a proximal median nerve injury. And these patients may have decreased grip strength or atrophy of the affected nerve area. It is often diagnosed clinically, although we may use an X-ray if there was trauma or we suspect a fracture, and treatment of this patient will begin conservatively and may progress to surgical intervention if needed. And a practice question might sound something like this. A 37-year-old woman comes into your clinic several weeks after a motor vehicle accident with complaints of continued left-sided hand weakness. The patient reports requiring surgery at the time of the incident, and while the fractures have healed, she has residual weakness in her left hand. On physical exam, you notice that there is extension at the fourth and fifth metacarpal phalangeal joints and flexion at the fourth and fifth interphalangeal joints. At rest, the patient also cannot fully form a fist and there is 2 out of 5 grip strength. What area of the patient's hand is most likely to have muscle wasting based off the nerve most likely affected? So this patient comes in and there is extension at the MCP for the fourth and fifth digits and flexion at the interphalangeal joints for the fourth and fifth digits. And so this is our presentation. And again, we're going to ask ourselves, is this at rest or were they trying to close their hand into a fist? And because this patient was at rest, we suspect that there is injury in the third and fourth lumbricals and that there is going to be a distal ulnar injury. And again, that ulnar nerve will be responsible for the hypothenar compartment of the arm, and so we may see wasting of the hypothenar eminence. All right, that's everything from me. Thanks for watching. Good luck studying, and I'll see you next time.
Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we will be talking about de Quervain tenosynovitis. So let's get into it. Let's talk a little bit about the name first. So teno referring to tendon and syno referring to synovial fluid, or the synovial sheath that surrounds tendons. And itis usually refers to inflammation. As we'll see, this is not always an inflammatory condition, but there's pain and swelling, and so the itis sticks. All right, so let's hop in and talk straight about our etiology. So this is generally going to be considered a mechanical overuse or trauma of the thumb, which then leads to that non-inflammatory thickening of the abductor pollicis longus and extensor pollicis brevis tendons. And if we take a little gander here at the back of our forearm, we can see this is the dorsal view of our forearm. And we'll start here and talk about the abductor pollicis longus. So this is a muscle going to come down from that posterior radius ulna and interosseous membrane, and it's going to come down and insert here at the base of the first metacarpal. We'll also talk about the extensor pollicis brevis, a muscle with a similar origin that will come down. We'll have a shorter muscle belly and then insert onto the base of the first phalanx of the thumb. And so these muscles will contribute to abduction and extension of the thumb. And so think about those kinds of motions when we talk about overuse of the thumb that will lead to this condition. But it doesn't always have to be about overuse. This can also be seen in inflammatory conditions like rheumatoid arthritis. And remember, a question stem isn't going to tell you that there is overuse of the thumb. They're going to hint at it with information about the patient. So this is something that we will commonly see in young parents as they're picking up their newborn baby a lot. Sometimes this condition is called mommy's wrist for that reason. Additionally, this may be something that we see in racket sport athletes or golfers as they're gripping that object. Overuse leads to pain. And again, I want to emphasize that although it is classically seen with overuse of that thumb, it is not necessary for de Quervain. So there can be inflammatory conditions. It can be idiopathic. All right, let's move on and talk about presentation. Now, this is a very simple presentation as there's really pain and there may or may not be swelling at the radial styloid. So where is that radial styloid? So if we look back to our diagram, we can see here is our ulna. Here will be our radius that is under these muscle bellies. And the radial styloid will be the most lateral part out here where the forearm meets the wrist. So in this patient, the radial styloid would be around here. And again, this radial styloid is the area where the abductor pollicis longus and extensor pollicis brevis are going to move through that first dorsal compartment on the posterior side of the wrist. And that is why we see the inflammation and pain at that area. If we have thickening of these tendons as they go through that first dorsal compartment, that's where we're going to feel the pain and that's where we'll have the swelling. And these patients will also have their pain worsened with extension or abduction of the thumb or that grasping motion. So remember, it's the extensor pollicis brevis and the abductor pollicis longus that are going to be the inflamed tendons in this pathology. So if we do those actions, that can further irritate these tendons and increase the pain in the patient. All right, moving on to diagnostics. This is often a clinical diagnosis, and that's because this is a very common and very simple pathology. Remember, we're really just talking about irritated tendons as they move through that first dorsal compartment. And because it's not necessarily inflammatory, we might not see the kinds of lab values that we would with inflammatory conditions like rheumatoid arthritis. And there's no damage to the bony structures, so we wouldn't see anything on an x-ray. And so generally, we don't need imaging for this unless there is concern for a fracture, maybe the patient fell. A test that is indicative of this condition would be a positive Finkelstein sign, which is going to be ulnar deviation of the hand with the thumb enclosed in the fist. So you can try this out yourself. You can wrap your thumb inside your fist, just go ahead and stick it out and deviate it in the ulnar direction. Remember, that's going to be toward that pinky, away from the thumb, as we can see down here. And if that elicits pain in the patient, that's a positive sign. And this makes sense, right? We have our extensor pollicis brevis and abductor pollicis longus running through here. And so when we deviate it in the ulnar direction, what we're doing is we're stretching these tendons out. And so if those tendons are already irritated, then that's going to further worsen the pain of the patient. Additionally, there should not be tenderness with palpation of the muscle bellies of the abductor pollicis longus and extensor pollicis brevis. This condition is really about thickening of these tendons here down at the wrist at the radial styloid. Up here in the posterior forearm, the muscle bellies are usually unaffected. And so if there is pain with palpation in that muscle belly up the forearm, in addition to just at the wrist, we might consider that there's an injury to those muscles. Some other differential diagnoses for you to think about if this patient does have a similar clinical presentation might be gout, where we would see uric acid crystals inside that synovial fluid if we aspirated it. Or if the patient had a rash in the area, in addition to arthralgias, we might consider a disseminated gonococcal infection. And of course, let's briefly go over the management of this condition. So we will opt for conservative as always and splint, use NSAID and corticosteroid injections to reduce the pain of the patient. Most patients with this condition respond very well to conservative treatment, but obviously if the symptoms are refractory, we may need to consider surgical intervention. All right, let's do a quick recap and then we'll do a practice question together. De Quervain tenosynovitis is the non-inflammatory thickening of the abductor pollicis longus and extensor pollicis brevis as they move through the first dorsal compartment on the back of the forearm going into the hand. It's associated with overuse and trauma of the thumb, but can also be seen in inflammatory conditions or idiopathic. And so this is something we might see in a young parent picking up their child or a sport athlete using their hand and wrist a lot for their sport, or maybe a world-class Tetris player who's using his thumbs all day. These patients will present with pain and possibly swelling at that radial styloid on the lateral part of the wrist, and that pain will be worsened with the motion of the involved tendons. This is usually a clinical diagnosis, and especially with a positive Finkelstein sign, we want to think about using this, and imaging is not typically indicated, especially if we don't consider there to be a high risk of a fracture. Conservative management with pain medication and rest are often enough to resolve these symptoms, but if not, we may need to resort to surgical intervention. And a practice question might sound something like this. A 27-year-old woman who is 7 weeks postpartum presents with pain in her left hand. The patient reports first noticing the pain about 4 weeks ago when holding her newborn daughter. Vital signs are within normal limits. On physical examination, there is pain elicited with Finkelstein's test, as well as pain with palpitation of the radial styloid. There are no changes in sensation to the hand, and grip strength is 5 out of 5, but elicits pain in the patient. What are the two muscles whose tendons are most likely involved in this patient's presentation? I hope you didn't cheat and look at this slide, but let's go over this patient's presentation. So she comes in, she's a young parent, and she noticed it while holding her baby, and there was pain at the radial styloid in addition to when she did the grasping motion. There's a positive Finkelstein's test, and so we are going to think about K.A.N tenosynovitis and likely irritation of the abductor pollicis longus and extensor pollicis brevis tendons. Now, this is a very simple pathology, and so if you get a question on this, it's very likely that they're going to do an anatomy tie-in. So feel very comfortable knowing that these are the involved tendons. All right, that's everything for me today. Thanks for watching. Good luck studying, and I'll see you next time.
Howdy everybody, welcome back to MSK. My name is Jonathan, and today we will be going over Dupuytren contracture. So let's get into it. So on the most basic level, it's going to be overgrowth of this tissue involved with the palmar aponeurosis and the palmar fascia. And that overgrowth of stiff tissue is what's going to cause your fingers to contract in, giving it its name of a contracture. So let's kick this off and talk about our etiology. So this is more common in older males of Northern European descent. So your question stem starts off. A 1,300-year-old Viking has recently been thawed from a block of ice and is in perfect health other than this contracture on his hand. You are already going to be thinking about Dupuytren from his Northern European descent. But there are also other associated risks it's important to know about. A family history, it's very, very commonly genetically associated. Also, recurrent trauma. So maybe your patient is a farmer or a construction worker, and so the recurrent damage and trauma to that area can promote an injury that will lead to proliferation and then give us the contracture we see in this condition. It can also be associated with liver cirrhosis and diabetes mellitus. Let's talk about pathophysiology. It's not an extremely well understood condition, but it's believed that fascial injury may contribute to an increase in myofibroblast stimulation and fibroblast proliferation, which will then lead to an increase in collagen deposition here in the hand. And this collagen deposition is what can contribute to the contracture as it limits the range of motion across that metacarpal phalangeal joint.
And I can see a biochemistry question tie-in with this kind of pathology. Remember that typically in a hand, the palmar aponeurosis will be mostly type 1 collagen. However, in this pathology, there's myofibroblast and fibroblast proliferation. And so this is similar to wound healing. And so these are going to be depositing type 3 collagen more than type 1. And so there will be more type 3 collagen involved in this collagen deposition.
So now let's talk about the presentation of these patients when they have that collagen deposition in their hand. So the first thing that patients will often see are painless nodules that will show up at the base of the 4th and 5th digits on that palmar side. And remember, the devil's in the details, painless nodules. If we had painful nodules, we might be thinking about osteoarthritis. If we had painful nodules that were colored or erythematous, we might even be thinking about something like infective endocarditis. And sometimes these painless nodules in Dupuytren can cause a skin puckering seen on hand, as we see in this image down here. So we can see that in this 4th digit, the skin is sort of puckered up, and that the 4th digit here is a little more flexed compared to all of the others that are able to lay flat on a table. And so as this disease progresses, these nodules may eventually lead to a flexion contracture and reduce the function of the fingers as they become increasingly flexed forward and unable to extend. Let's take a second here and think about differential diagnostics that have varying presentations so we can distinguish them. So consider palmar fasciitis, which is an inflammation of that palmar fascia. Now that's a paraneoplastic syndrome, and that's indicative of malignancy. And so because it is the consequence of a cancer somewhere else in the body, we're going to see it affect all the fingers, and it's going to be bilateral. Dupuytren contraction, on the other hand, can possibly only affect one finger in the whole body. Additionally, there's stenosing tenosynovitis, or sometimes called trigger finger, which we talk about in another video. In that condition, the sheath that covers over the flexor tendons can become stenosed or inflamed and can cause locking of the finger. And in that condition, then there can be painful popping and unlocking of that finger. But in Dupuytren contracture, it's more subtle because that collagen is sort of just pulling in and causing that subtle contracture, and it might not necessarily be painful. All right, let's move on and talk about diagnostics. So like most things in this chapter, this is often a clinical diagnosis.
Additionally, as a diagnostic tool, we might use a tabletop test in which we ask the patient to put their hand palm down on a table and to flatten it out. And if the patient is unable to flatten that hand and get their palm onto the table due to these flexion contractures, that is another positive sign for Dupuytren contraction.
Additionally, we may use imaging like ultrasound in order to visualize the nodules. So on an ultrasound, these nodules or cords are likely to show up as hypoechoic or dark, and they're going to be superficial to the flexor tendons. And finally, we'll talk about management. So as always, we'll begin with conservative treatment and splint the hand, use corticosteroid injection, and use physical therapy for the hand. In addition, we may use injection called collagenase injections, in which we hope to break up some of the collagen that could be leading to the contracture in hands. Of course, as always, we may need a surgical intervention if the symptoms become very severe or are refractory to treatment. But something to keep in mind is that this often has a high rate of recurrence even with treatment. So sometimes patients can get a surgery, remove the collagen, and the collagen can grow back. All right, let's do a quick recap and then we'll do a practice question together. Dupuytren contracture is not fully well understood, but it's believed that fascial injury may promote fibroblast proliferation, which will cause collagen deposition in the hand, typically at the base of the fourth and fifth digits at the metacarpal phalangeal joint. It's more common in older males, especially of Northern European descent, and family history is an important risk factor. Additionally, recurrent trauma, liver cirrhosis, and diabetes mellitus may also be associated with this condition. The disease will begin with painless nodules that begin likely on the fourth and fifth digits, and skin puckering of the skin may be seen, and this may eventually progress to flexion contracture, reducing the finger's ability to extend. It's typically a clinical diagnosis, although we may view these nodules as hypoechoic on ultrasound, and a positive tabletop test in which a patient cannot flatten their fingers onto a tabletop may also suggest this is Dupuytren contracture. Conservative management may include injections, including collagenase, physical therapy, and it may progress to surgical intervention, but recurrence is high with this condition. And a practice question might sound something like this. A 42-year-old male presents to your clinic with reduced mobility in his right hand. The patient is a construction worker and first noticed a nodule at the base of his ring finger and then reduced mobility of the finger. Vital signs are within normal limits. On physical exam, there are no changes to sensation and grip strength is 5 out of 5 bilaterally. The patient can flex and extend his ring finger without pain, but the ring finger is unable to fully extend and lay flat on a table along with the other fingers.
What is the collagen type most abundantly found in the fascia of the affected hand of this patient? So this patient has a very classic presentation of Dupuytren contraction. There are painless nodules that progress to a flexion contracture, and now he is unable to straighten his fingers on a tabletop because of that contraction. But the question is about collagen type. So in a healthy patient, the pulmonary aponeurosis is predominantly made of type 1 collagen. But in this pathology, remember there's myofibroblast and fibroblast proliferation, which are going to be depositing a type 3 collagen. And so in the fascia of patients with Dupuytren, there's an elevated type 3 to type 1 ratio. And so the most abundantly found collagen in this patient's affected hand will be type 3 collagen.
All right, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we will be going over the ganglion cyst. And it's a bit of a misnomer, as it does not actually involve ganglion cells, and it's not a true cyst because it doesn't have an epithelial lining like true cysts normally have. Instead, a ganglion cyst is an accumulation of synovial fluid, usually on the back of a hand, and it's a pretty simple pathology with relatively low chance of severe complications. So let's hop in and talk about our etiology. So this is generally considered idiopathic. We're not exactly sure what causes the fluid to start to build up in the hand, but it may be due to underlying arthritis or trauma. This is something that's more commonly seen in patients with something like osteoarthritis, so there's an association there. The pathophysiology of the ganglion cyst is also not perfectly understood. So there's either herniation or degeneration of the connective tissue that's around a joint or a tendon sheath. And that leads to synovial fluid buildup, which forms a cyst near that joint or tendon sheath. And like I said before, this does not have an epithelial layer, which means it's not a true cyst and may be considered a pseudocyst. And recall that synovial fluid acts as the lubricant in these tendon sheaths, and mucin is its predominant component. And so you may also see this referred to as a mucin-filled cyst. So now we'll move on to talk about the presentation. So these cysts are often asymptomatic. A patient will notice them, but if they're not compressing any structures like nerves or arteries, they're not likely to cause any symptoms. But if there is compression of these structures, then that may lead to pain, changes in sensation, or weakness. Also worth noting is that it typically presents as a fluctuant swelling on the dorsal of the wrist. And so even when this mass comes in, it might change in size as that fluid moves in and out of the cyst along the hand. And this mass is likely to be mobile and, importantly, non-tender, which might help distinguish it from something like infectious tenosynovitis, which will be painful. All right, let's move on and talk about diagnostics. So this will be clinically diagnosed. If a patient follows this clinical picture of a fluctuant swelling mass, then we're likely to think of a ganglion cyst. Importantly, the cyst will transilluminate with light. Remember what we said earlier, it's a fluid-filled cyst, and so fluid is going to be transilluminative if you hold a light up to the cyst. This is in contrast to something like a lipoma, which is a benign growth of adipocytes. That's going to be a solid mass, and so it won't transilluminate. And although imaging is not typically indicated for this presentation, if there is an X-ray, it should appear normal, and we may use that to rule out a fracture. Additionally, ultrasound may differentiate from a vascular aneurysm. So we can take a look down here at the ultrasound of a ganglion cyst. And we can see here's the tendon sheath, and here is the fluid-filled cyst showing hypoechoic on the ultrasound. And because this is just a pocket of fluid sitting above that tendon sheath, it's not going to be moving, and so it won't show as motion on a Doppler ultrasound, whereas a vascular aneurysm will show as moving on Doppler. So again, comparing this to other differentials, the epithelial layer will distinguish this from something like an epidermoid cyst, which does have a squamous epithelial layer. And the transillumination test will confirm that it is a fluid-filled cyst, and so we can distinguish that from something like a lipoma. And finally, let's talk about management. So these will often resolve spontaneously. And if there is no symptoms in the patient other than the noticeable mass, we might not use treatment and hope that there is spontaneous resolution. However, as we've talked about, anything in the hand can compress these nearby structures. And so if we do have a cyst that's compressing down on the median nerve or the ulnar nerve, and the patient's presenting with symptoms, then we may want to aspirate or surgically resect the cyst. All right, let's do a quick recap, and then we'll do a practice question together. So a ganglion cyst is the buildup of synovial fluid near the tendon or sheath, often found on the back of a hand. Importantly, that's without the epithelial layer. We're not exactly sure what causes this, but it may be associated with arthritis or other osteoarthritic diseases. They're often asymptomatic and may present as little more than a fluctuating swelling on the dorsum of the hand or wrist. It's often diagnosed clinically, especially with transillumination with a light, and imaging is not typically indicated for this presentation. Oftentimes, these cysts will just resolve on their own without any treatment, and no treatment may be necessary if the patient is completely asymptomatic. But of course, we may aspirate or surgically resect if the patient does have symptoms such as compression onto a nerve or an artery. And a practice question might sound something like this. A 62-year-old male presents to your clinic for a wellness checkup and tells you that he noted a painless lump in his hand. The patient reports that he noticed the mass a couple weeks ago and that the mass changes in size, but he can't identify any pattern with the fluctuation in the size of the mass. The patient also reports that there have been no changes to sensation and the mass is not painful, and he often forgets about it. Vital signs are within normal limits. On physical exam, you notice that there is a non-tender, firm, well-circumscribed, and mobile mass that transilluminates on the posterior wrist. Would you recommend that this patient have his mass surgically removed? And so we have a pretty classic presentation of a ganglion cyst. We have an older patient with a fluctuant swelling on the dorsum of the wrist, which transilluminates with light, and because it's asymptomatic, we would not advise that this patient get his cyst surgically removed. All right, that's everything for me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. My name is Jonathan. Welcome back to MSK, and today we are going to be going over 3 different injuries of the fingers. So let's hop into it. All right, let's take a look at my little doodle down here to orient ourselves because we'll be talking about the finger. So here's going to be our anterior side and our dorsal side. This is sort of a medial view of the tip of a finger. Let's say it's our middle finger. And so we have our flexor digitorum profundus reaching to the anterior side of that distal phalanx. And here we have our extensor digitorum that will contribute to extension of that distal phalanx. Okay, so now we can hop into our slide and start off with mallet finger, which will be hyperflexion at the distal interphalangeal joint. So what would that look like on our finger down here? So if we're going to hyperflex it, the tip of our finger here is going to flex far forward. And you can imagine that's going to stretch out this extensor digitorum. And so we're going to have damage to the extensor digitorum in mallet finger. And this is usually from some kind of traumatic blow, like jamming the finger. So it's a very common sports injury if a basketball were to come in and push down on this finger, causing it to hyperflex, and boom, we have damage to the extensor digitorum. In contrast, jersey finger is going to be hyperextension of the distal interphalangeal joint. So again, looking back here, if we're going to hyperextend it, our tip is going to extend backwards, again, stretching out that FDP, and so we are going to have damage to the flexor digitorum profundus. And this is going to be more common in a traumatic incident that actually pulls the finger back. So this can happen if a finger is caught on an opponent's jersey. I had a friend, it happened to him when it was caught on an opponent's pocket. And so some kind of force is going to hyperextend that distal phalanx back, damaging the FDP. And the last finger injury we have is trigger finger, which is stenosing metaplasia of the finger tendon. Now this is different than the other two because it doesn't happen here typically at the distal interphalangeal joint. Instead, this is typically found at the metacarpal phalangeal joint, which on these diagrams would be here, it would be here, it would be here because this is the thumb. And so what does this stenosing metaplasia of the finger tendon really mean? What it means is that because it's getting stiffened at that metacarpal phalangeal joint, we're losing that tendon's ability to slide comfortably over the joint. And unlike our other two conditions, this is often idiopathic. These two, mallet finger and jersey finger, are going to usually be from sports injuries, traumatic incidences. Trigger finger, in contrast, does not require trauma and can often set in on its own without an understood cause. Okay, let's move on and talk about presentation, and we'll start with mallet finger. Now again, I think this is a great example. If we understand the anatomy, we don't have to memorize things, the presentation will make sense. So there's obviously going to be pain and swelling because there's injury. And remember what we said about mallet finger is damage to the extensor digitorum. And so because of that damage, we're going to have loss of DIP extension in the affected finger. Again, if we don't have this extensor digitorum working properly, we're not going to be able to extend the finger. And so that's what we see in this presentation right here. We can see that as the finger is extended at that distal interphalangeal joint, it's still flexed. It's not able to extend all the way out. And that's because we have damage to that extensor digitorum. And so this is going to be our classic mallet finger presentation. Jersey finger will also have that pain and swelling, again, because we have injury, but there will be a loss of DIP flexion in the affected finger, right? Flexor digitorum profundus is the only tendon that's going to be contributing to flexion at that distal interphalangeal joint. And so if we have damage to that tendon, or sometimes a complete rupture, we're going to lose our ability to flex in that affected finger. Also recall that across any joint in the body, there's a balance between all the muscles that are acting on that joint. In this case, extensor digitorum and flexor digitorum profundus. And so if we have injury to one of those, in this case, let's talk about jersey finger, we have injury to the flexor digitorum profundus, our patient is going to come in with an extended finger because the extensor digitorum is the only muscle that's still acting on that finger. Trigger finger is going to be a little different from these two as we're going to have painful locking of that finger in flexion, like we see in this patient here. So recall that this is a stenosing metaplasia. And so what happens is that tendon gets tough and it's unable to glide. And so we may have a clicking in and out of flexion. It may be described as popping or locking, and the patient's hand may get locked in this flexed position. And when they extend it, there's a painful popping or snapping sound. Okay, we'll move on and talk about diagnostics. Again, this is often a clinical diagnosis because if we have a clinical picture, we can induce what's happening. If we see that this patient is unable to extend, we understand that there may be damage to the extensor digitorum and that there was a hyperflexion injury. Similarly, in the case of trigger finger, this is going to act at the metacarpal phalangeal joint. Now, the other pathology we talked about common at the metacarpal phalangeal joint is a Dupuytren contracture. But again, this is going to be a puckering of the skin that causes a subtle contracture of the finger. Trigger finger, or stenosing tenosynovitis, will cause this painful locking of the finger in flexion. In the case that there's trauma, we will also be indicated to get an imaging, and X-ray may show an avulsion fracture. Now remember, an avulsion fracture is just when a small chunk of bone becomes removed from the rest of the bone because of the traumatic injury. So if we take a look at this image, we can see that the dorsum of this finger, the thumb, has a small avulsion fracture at the base, which is on the dorsal side. So what is the injury with this patient? So this will be mallet finger, which is from a hyperflexion. And that makes sense, right? If we had our distal phalanx flex down, then this extensor digitorum on the back is going to pull really tightly, And that's what's going to yank this little piece of bone off the rest of the finger. And lastly, we'll talk about management of these conditions. Starting with mallet finger, this may be addressed with conservative treatment. We may splint the hand in order to properly rest it, use NSAIDs and analgesics for pain, but it may require surgical intervention, especially depending on the degree of injury. In contrast, jersey finger will always require surgical intervention. Because that hyperextension injury is going to be severe damage to the flexor digitorum profundus, we're going to need surgery in order to repair it. It won't heal on its own. And so this is an important diagnosis to not miss. Because it won't heal on its own, if you falsely diagnose this as a sprain and send the patient home and tell them to just take Tylenol and rest it up, they're not going to get better. The treatment of trigger finger will also begin with more conservative treatment with splinting and corticosteroid injections and physical therapy in order to reduce the immobility of the hand, but may require surgical intervention as this is often a progressive disease, and it can begin with minor locking and progress to severe and more painful locking and inability to use the finger. Okay, let's do a quick recap and then we'll do a practice question together. So there are three main finger injuries we're talking about. Mallet finger, which will be hyperflexion, leading to damage to the extensor digitorum. Jersey finger, which will be hyperextension, leading to damage to our flexor digitorum profundus. And trigger finger, which will be a stenosing metaplasia, often at that metacarpal phalangeal joint, which will lead to a clicking in and out of flexion. In mallet finger, because we have damage to that extensor digitorum, we're going to have a loss of extension at the distal interphalangeal joint. In jersey finger, because we have damage to the flexor digitorum profundus, we will have loss of DIP flexion in the affected finger. And in trigger finger, because of that stenosing metaplasia, that tendon sheath is not going to slide very well, and it's going to get caught, and often it gets caught in flexion, and the patient may have to click or snap or pop their finger painfully in and out of that flexion. These injuries are often clinically diagnosed, but we will often take an X-ray in order to check for bony structure damage, as there can be an avulsion fracture, very commonly with mallet finger or with jersey finger. Treatment of mallet finger and damage to the extensor digitorum can be addressed conservatively, but may require surgical intervention. In contrast, damage to the flexor digitorum profundus in jersey finger will always require surgical intervention. And trigger finger can begin conservatively, but also may require surgical intervention if it progresses to the point of severe impairment of the patient. And a practice question might sound something like this. A 24-year-old female comes into the emergency department after injuring her finger during a field hockey match. She reports feeling her hand caught on an opponent's shirt and having it pulled back, and has felt 8 out of 10 pain in her middle finger since. On physical exam, there is swelling of the middle finger, and the patient is unable to flex at the distal interphalangeal joint of the middle finger. X-ray imaging of the hand show no fractures. Appropriate treatment is administered to this patient, and she is scheduled for surgery. What is the nerve that innervates the muscle of the tendon most likely injured in this patient? So this patient describes a classic of having her finger caught on into opponent, and so we suspect a hyperextension, especially because there's loss of flexion in that affected finger, and she is scheduled for surgery, and so we suspect a jersey finger. Now, that means that her injured tendon is the flexor digitorum profundus, and so what innervates the muscle of this tendon? Remember that the flexor digitorum profundus is dual innervated with both the ulnar and the median nerve, but we're talking about the middle finger here, and so the middle finger is going to be in the median nerve distribution of the flexor digitorum profundus. All right, that's everything for me today. Thanks for watching. Good luck studying, and I'll see you next time.